All right, so we're going to go over some sacral landmarks. When you're doing your seated flexion test, you're going to come under the PSIS like this, especially if they're going to be seated with feet on the floor. They're going to flex forward and one side, or maybe both. It's hard to tell because this is not a person, but they're going to have one side go up further and faster, and that's going to be your lateralization test for the side that has the problem. For our sacral sulci, remember that we're checking just medial to the PSIS in this divot here, and your thumbs are going to be checking which side is deeper versus more, or deeper or anterior versus posterior or shallow. For the ILAs, you're coming straight down, and this border on the inferior aspect of the sacrum is going to be your ILA check, and your thumbs are going to be detecting the same thing if one side is deeper or more anterior versus if one side is more shallow or posterior. So for our seated flexion tests, we're going to palpate for the PSIS. There's one on the left, one on the right. I'm just underneath them. And then we'll have our patient flex forward. So slowly forward. We see that left side is coming up higher. And then come on back. My left eye is over the midline because I'm left eye dominant. So we have our lateralization test that the left side is going to be the side with the dysfunction.
Okay.
So we know that the left side is a problem. Now let's check our spring test. So if you can go into Sphinx position here. Thank you. And then I'm going to use the heel of my hand on the base of the sacrum, and I'll just spring down. So good. She does have spring, so our test is negative. Remember, if she does not have spring and there's literally a wall that you're going up against, that means it's a positive spring test and that it does not have spring. So we know it's probably going to be either a flexion or a forward torsion. You can go face back down. So let's check the sulci. So when I put my thumbs, remember, just medial to the PSIS, and we check the sulci. So I'm just really compressing down to the level of the bone. Her left side is very slightly deeper than the right. So it's anterior / deep. The right sulcus is posterior / shallow. And then if I drop just down and I keep palpating for the ILAs here. So when I check the ILAs, if I push, this left or right ILA is shallow and posterior. This left ILA is deep or anterior. So we know, based on those landmarks, that she has a right-on-right sacral torsion. Now, if we had a backwards torsion, let's just say if it was a left-on-right, she would still have this left seated flexion test be positive. She would have a positive spring test, so there would be no spring. And then if we check the sulci, this left sulcus would be more posterior or more shallow. This right would be deep. This right ILA would be deep, and this left ILA would be shallow. So it would be this kind of backwards left torsion, left on a right axis. If it was a, let's say, a unilateral flexion on the left, we would have a deep sulcus on the left, a shallow on the right. It would be a negative spring test because there would be spring since it's a unilateral flexion. This ILA would be shallow, and this ILA would be deep. So we're going to show you the treatment for her twisted up sacrum. She has a right on right sacrum. So if you want to lie axis side down, so lie on your right side, and you can hug the table, so chest is down. So this is a down, down, down treatment, axis down, chest down, and then patient's force is going to be up while the physician's force is down. I'm just going to bring the legs down like so, and then gently push your legs up into the ceiling. 3, 2, 1, and relax. And then again, 3, 2, 1, and relax. And then one more time, 3, 2, 1, and relax. Final stretch there. Back up, and then you can lie face down. Okay? And then we recheck, just like how we diagnosed. Cool. So if we're going to treat using up, 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 which is a little more comfortable for the patient, however, the caveat is that this is not a Nicholas and likely won't be tested on boards in this way. However, we think clinically, it's a little more comfortable because her IT band and femur aren't smashing into the table with each new barrier. Her axis side, or the right side, is up, her chest is facing up, and then physician's force or counterforce is going to be coming upwards into that barrier. So just like before, we are going to monitor the sacrum. I have my thigh right here as a fulcrum for her knees to pivot around. I'm gently grasping under the ankles here, and then her force is going to be pushing down. 3, 2, 1, and relax. Do that again. 3, 2, 1, and relax. And then one more time. 3, 2, 1, and relax. Final stretch here. Okay, good. Yeah. Now we're going to be treating a left on right, also known as like a backwards torsion. So we're going to be treating this with the axis side down, or the right side down. Her chest is going to be up, and then the top leg I'm going to use and push the leg down as with my counterforce as she pushes that leg up. This is going to recruit the piriformis to pull that left margin of the sacrum forward, because remember, it's a left on right dysfunction. So again, monitoring sacrum here. This comes off, and then I'm just having my counterforce on the lower extremity, gently push up towards the ceiling. 3, 2, 1, and relax. And then do that again. 3, 2, and relax. And straighten that leg a little bit. Yeah. Last one. Push up. 3, 2, 1, and relax. Final stretch here. Cool. This is going to be up while the physician's force is down. So I'm going to just gently bring her legs across, monitor the base of the sacrum here with my other hand. And then what we're going to do is I'm just going to bring the legs down like so, and then gently push your legs up into the ceiling. 3, 2, 1, and relax. And then again, 3, 2, 1, and relax. And then one more time, 3, 2, 1, and relax. Final stretch there. Back up, and then you can lie face down. Okay, and then we recheck. So here we're going to explain unilateral flexions and extensions as well as bilateral flexions and extensions. So let's say we have a left unilateral flexion like we described before. It's essentially going to look somewhat like this. Remember, the bone isn't bisected, but the bone has a little bit of an ability to twist and be in a slight unilateral pattern. So essentially it's going to kind of look just like that, with the left sulcus being deep, the left ILA being shallow, and vice versa for the right side. So with this, we're going to need to push down with respiratory assist. So your hand is kind of positioned this way, you know, and in the treatment, we're going to actually do this to push all of our force into this left ILA. And then as she inhales, you're going to accentuate it. And then on the exhale, you're going to resist that sacrum trying to drop back forward. So when she inhales, you're accentuating on the ILA, and then on the exhale, you're resisting, inhale. So you're essentially correcting that right-sided flexion. Now, with a right-sided extension, it's the opposite. So you have your hypothenar eminence here, and when she's inhaling, you resist, and on the exhale, you push down on that left side to then accentuate that flexion-based force to prevent it from continuing to extend. So flexion versus extension. Now for bilateral, it's the same principle. It's just the heel of your hand is going to be across the sacral base. So for flexion, it's going to be bilaterally flexed, bilaterally extended. If it's bilaterally flexed, you're going to actually be more rocking the sacrum towards the coccyx, and you're going to enhance inhalation and resist exhalation. If it's extended backwards, you're going to have the heel of your hand up near the sacral base. You're going to resist inhalation and accentuate exhalation. Cool. All right, so next we're going to treat the left unilateral flexion dysfunction. So what we'll do is we will loose pack this joint slightly by bringing the left leg into abduction. If you want to scoot a little to the right, So left leg into abduction with slight internal rotation, about 15 degrees. That's going to loose pack this side of the SI joint here. We'll have our hypothenar eminence on the ILA. And then since it's a flexion dysfunction, she can stay down. She doesn't have to go into Sphinx for this. So as she inhales, I'm going to accentuate the inhalation, and then I resist the exhalation. And then inhales and exhales. And you can do this for 5 to 7 respiratory cycles. Inhales and exhales. And then I'm, again, accentuating inhalation and resisting exhalation for this technique. If we did the opposite, if we treated a left unilateral extension, I would have her pop up into Sphinx position. That's going to allow this to drop into flexion a little bit more easily. We're going to do the opposite, have my left hypothenar eminence on the sulcus, which is essentially at the sacral base. Interlock my fingers here, and then she's going to inhale. I'm going to resist, and exhale. I'm going to put pressure down into that sulcus. Inhale, resist, and exhale. We'll just do a few cycles of this. Okay. Now, if we were to treat a bilateral flexion, we would do something similar, but we would have both joints loose packed, so slight abduction of 15 or so degrees with some internal rotation. So that kind of opens up the SI joints. Bilateral flexion means I'm going to have the heel of my hand slightly towards that coccyx, and then do a sacral rocking motion. She's going to take a deep inhalation, and I'm going to follow that. And then with all of my force going towards the table on that heel of my hand towards the coccyx. Inhale, I accentuate, and I'm resisting exhalation with each cycle. Good. And then if we were to treat an extension, she would go back in the Sphinx position. I'd keep both legs abducted to loose pack the joint. And then I have the heel of my hand on the base of the sacrum. And as she inhales, I'm resisting. And on exhalation, I then push down towards that table, accentuating the exhalation or that flexion of the sacrum. And then as she inhales, I'm resisting. And then exhale, I'm following. All right, and that's how you treat the unilateral flexion extensions and the bilateral flexion and extensions.